Hi, my name is Eyob, and I'm a registered respiratory therapist in the medical intensive care unit. I just returned from a 2-week vacation. Today I'm taking care of a mechanically ventilated patient with emphysema. Her name is Mrs. Tubbs, and she is 50 kilograms of ideal body weight. She has lived with this diagnosis of chronic obstructive pulmonary disease, COPD, for almost 10 years. The attending physician wants to be very cautious in the weaning and liberation of mechanical ventilation. For this patient, as it has been difficult in the past keeping Mrs. Tubbs breathing spontaneously after previous extended stays on the vent. My role in performing successful weaning on a removal of positive pressure assisted breathing would be to perform an arterial blood gas for ventilation and oxygenation, check for bedside ventilator parameters such as her MIP and NIF, check and make sure blood pressures and heart rate are within normal limits, verify that the underlying disease process has been reversed, make sure sedation is off so we can attempt a spontaneous breathing trial. My role is keeping Mrs. Tubbs off of mechanical ventilation after extubation is by closely monitoring and performing a thorough patient assessment such as protecting how can she protect her how well she can protect her airway, how well can she mobilize secretions, helping her by elevating her head of her bed, have her going through bronchopulmonary hygiene exercises, and if necessary, placing Mrs. Tubbs back on a BiPAP before re-intubation is considered, and any necessary meds such as albuterol or duoneb if needed. Right now, I'm currently working with Mrs. Tubbs in the management phase of mechanical ventilation. How I would describe Mrs. Tubbs' ABG results would be not a typical normal lung person. Since she is a COPD, her ABG values would be different from a normal lung person. From her pH would be 7.34 to 7.37. Her PaO2 would be 55 to 65 torrs. Her PaCO2 would be 55 to 65 torrs, and her bicarb would be 28 to 34. Her saturation would be 88 to 92, and that would be normal for her. We don't want to over-oxygenate Mrs. Tubbs, so in that way that we would prevent her from being obtunded and knocking out her respiratory drive. Some special precautions that I would need to consider while I progress to weaning Mrs. Tubbs to medical mechanical ventilation assistance is to observe her heart rate and make sure she's not bradycardic or tachycardic, and monitoring her blood pressure knowing that she's in her normal range. And I would have to look at her respiratory rate and make sure she's not going above 30 breaths per minute over the ventilator or even 20. I want her to be having a restful ventilation status. And I'll be observing Mrs. Tubbs to make sure that she's not working for breath or agitated or in any type of respiratory distress as we progress towards the weaning status. And even before this, I would make sure that her underlying issues are being treated or reversed. Right now, we're going to take a look at Mrs. Tubbs' vent settings. We have her on a mode of mechanical ventilation of volume controlled with SIMV. Her set total volumes are 450. Her set rate are 10 breaths per minute. Her total rate is equaling out to be 13 breaths per minute, so she's doing 3 by herself. You have a PEEP of 5 for the oxygenation over, and the FiO2 of 35% for oxygenation too. And we have her pressure support set of 5, and her spontaneous breaths are bouncing around at, let's see, about 485 right now, so that's really good, but she's been doing around 250. That's it, right? Right now, Mrs. Tubbs' vital signs are normal for her pulmonary status and cardiac history. Her SpO2 is hanging around 91%, and that's good for her and how her body operates. She's going to be around 88 to 92 for the COPD condition that she has. Now, Mr. Nose wants us to wean her down to an SIMV rate to a minimum of 4. So how I will perform these rates of changes will be in increments of 2, and to do that by every 30 minutes. Now, how I will manage other settings such as FiO2 and PEEP will be by monitoring her pulse oximetry. That's going to be my number one go-to, see how well she's oxygenating. If I see that pulse ox go drop down below 91 to 87, even I'm going to either add more FiO2, bump her up to 40, or I could add more PEEP, but I'll go for FiO2 for first resorts. And then for the ventilation status, I can always look at um, her end-tidal CO2. Now, for monitoring the pressure support, I'll monitor the patient and make sure her tidal volumes are higher and her depth of breathings are shallow and she's breathing at normal consistency. Now, how we manage the ventilation oxygenation invasively is through an AVG. That's going to give me an accurate portrayal of how well her body is being able to oxygenate and ventilate. And I can do that invasively by the pulse oximetry or the end-tidal CO2. Some other ways that I'm going to use my patient assessment skills for Mrs. Tubbs is observing her and making sure she's comfortable before I leave this room at her weaning settings. So I'm going to make sure that her chest is rising up and down, her volumes are steady at her norms, and that she hasn't been dramatically affected to the changes that I have made. Whoa! So we're back here again, and we found Mrs. Tubbs as our contact precaution. Sucks for her. So I've successfully weaned Miss Tubbs down to an SIMV rate of 4 breaths per minute. Now after an hour, I'm going to want to come back and obtain my weaning parameters. I'm going to go and look at her spontaneous tidal volumes and make sure they're about 6 to 8 milliliters per kilograms per her ideal body weight. Now right now I'm seeing Miss Tubbs is achieving that. So I'm going to go to my next category, and that would be respiratory rate. I'm going to want her respiratory rate to be below 30. The good point would be 12 to 20. It's the norm. For Miss Tubbs, I'll accept a little bit higher since she is a COPD. And my next one is the Tobin index. That's going to tell me how her breathing is, how rapid and shallow. So I can take her tidal volume and her respiratory rate, and I'll divide her tidal volume by her respiratory rate, and I'll want something below 100, and that'll indicate she's doing well with her Tobin index. The next one, I can wake Mrs. Tubbs up, and I'll have to instruct her on how to do a vital capacity. I'll go over to my machine, and I go to my vital capacities, and I'll instruct Miss Tubbs on how to do this. I'll wake Miss Tubbs up, get her to let me know that she can follow directions, and ask her to take the biggest breath she can pull. Breathe real big, Miss Tubbs, and ask her to exhale it all out until I see what she's able to exhale. Now the normal is around 3 to 5 liters, but we're going to aim for 10 to 15 milliliters per kilograms of her ideal body weight. Our next category is measuring a NIF, and that'll be the same thing. I'll ask her to follow some instructions, and I'll ask her to pull on her as breathing as deep as possible, as she possibly can. So I'm at the ventilator machine measuring her NIF, and the acceptable range would be to negative 20 centimeters or below that, and I'll know she's able to inhale a sufficient amount of room air where she can breathe without the ventilator. Now, after I've done that, I'm going to measure her oxygenation non-invasively. I'm going to go back and to her pulse oximetry and see how well she's able to oxygenate. And she's above 88 to 91 or even above that, then that's acceptable. That's what we would like to see. Now I like to measure her carbon dioxide values, and I can do that by her end-tidal CO2 monitor. And I want a goal of 35 to 45. In between there is a good spot for me to know that she's actually ventilating and able to blow off her CO2. So we have an update from Mrs. Tubbs. From last time, she's passed her weaning trial and we decided to extubate her, and I placed her on the nasal cannula at 2 liters per minute. Now, once I did that, she almost immediately became tachypnic, and her SpO2s decreased all the way down to 82. You have a bad sign right there. She's breathing really fast. And from my assessment of Mrs. Tubbs, I can see that she's breathing really fast and really shallow. So we're going to do an ABG on her and see really what's going on with oxygenation and ventilation. My predicted values of what her ABG values would be a high pH, out of normal, a high CO2, which is out of range, and a low PaO2 because she's in acute alveolar hyperventilation. So I just came back and I shared my findings with Dr. Nose. And we talked about, we come to the agreement that Mrs. Tubbs is going to need some BiPAP therapy to help her with her assistance on the spontaneous breathing effort she's not being able to do. So before I place her on this BiPAP, I'm going to have to measure her face, her nose, and her mouth area to see what size she would be. Yeah, so she's a small lady. She has a small mouth and nose region, so we're going to go with a small face mask. Now I'm placing this on her. I will explain to you why I'm using a face mask rather than a nasal mask. Now, Mrs. Tubbs is in respiratory distress, and she'll be breathing through her mouth a lot more. And when she's in this type of respiratory distress, a nasal mask isn't going to help her out with her lack of oxygenation through her mouth breathing. A nasal mask is going to be typically with a person with sleep apnea who's a nose breather. That's what we usually would reserve that type of mask for. Okay, so we've got her fitted. So I've come around the other side to her BiPAP therapy machine, and I'm going to place my initial settings, and I'll put her IPAP to 10, EPAP to 5, so we can get a driving pressure of about 5 centimeters of water, and that's what's going to really help her ventilate right now. I'll titrate this up or down depending on how she tolerates it and how her oxygen is doing and her ventilation. And I'll put her oxygen FiO2 up to 60 for now. I might bring that up or down, and that's all depending on my patient and her reactions towards this therapy. My alarms, I'll go with my high pressure alarms, so my low pressure alarms, 10 above and 10 below of what I'm actually getting right now. And then I'll put my apnea alarms at about 20 and my low minute ventilation at 1 above and 1 below. At 1 above and 1 below. Now, after I've done my initial settings and my alarms, I'm going to observe my patient and see how she's tolerating this. I'm going to ask myself, is this helping her? Is her shallow breathing? Is her rapid and shallow breathing still going on? And ask myself, how can I fix that problem? If this isn't even helping her, what else can I do? I can make that driving pressure larger. If she's an oxygenation pressure problem, I can make that EPAP a little higher. There's multiple things I can do, but that's all depending on how my patient is, because I'm treating the patient and not the monitors. All right, so I'm back with Mrs. Tubbs, and her respiratory efforts are deteriorating on the BiPAP, and her respiratory status is actually failing, even with the BiPAP. So I'm going to have to look at what I can find to help reverse this. So I'm going to go back to my ABGs, and I'm going to see what came back for those results. And I will see that her pH is going to be dramatically low because her CO2 is very high at this point. So she's running well above 45 millimeters of mercury with her CO2. And then I'm going to go back and observe my patient, which I can tell that she's probably right now very lethargic. She's retaining a lot of CO2. She's probably coming in and out of consciousness. She's not going to be able to answer questions, and that her pulse oximetry is going to let me know that she's probably not oxygenating as well. Very predictable. And I'm going to have to call a rapid response for Mrs. Tubbs. I already know that her respiratory effort is decreasing. I've on the vent. I've increased that pressure gradient, and she's not doing any better. And I've increased her FiO2. We're going to have to call that rapid response in the future's notice. We're going to know that at this point, this is where we need to call a rapid response from Mrs. Tubbs. We have this noted in her record so we don't go through this again, or we can prevent it. And I have to after a while initiating that rapid response, so I don't have to wait. They're not going to come immediately. I'm going to have to stay in the room. I'm going to have to monitor Mrs. Tubbs, make sure she's okay. I'm going to have to maybe reassure her, get her breathing a little better. I might have to make some changes on her BiPAP. If she becomes apneic, guppy breathing, or anything, I might take out the bag valve mask, and I might have to bag her if worse comes to worse. Hopefully that doesn't happen. And then after they come, I'm going to have to get my intubation set up going. And I'll have to set that up for the doctor, anesthesiologist, whoever it is that is going to be intubating. I have my ET tube right here. I'm going to have about three, one size bigger, one size lower, and then one typical size for a lady of Mrs. Tubbs' age. And I'm going to get my syringe. I'm going to pop that onto the pilot balloon. And I want to see that if it's inflated or not. And as inflated, there's no holes, so that's a perfectly well ET tube. And I'm going to want to put some gel on that and wait for the doctor to come and insert that. And I have my stylet in there, drawn in, curved to try to get right into that vocal cords. Place that down. I'm going to have capnography test for placement into the lungs, and we'll make sure that we're not in the esophagus. And to do this, we're going to need our blade, our Mac and our Miller, and our handle. Check, make sure the light's on, and the light is on. Turn that off, we'll place that back down. We'll make sure this is all sterile. I have my E-tube placement right here. That's a secure ET tube. Make sure it's not going to come up or down. It'll be placed right there so we can go ahead and start bagging her or place her on the vent if we can. And before we even do this, the doctors and the nurse will have some sedatives and paralytics for them to administer to make this process easy, because you don't want to try to intubate her while she's still conscious.